Welcome to the Gamut of Performance Podcast, Episode 7. This podcast has been an awesome journey so far. 7 episodes has gone by in what seems like a week. So we'll see where this thing ends up in the next few months, and hopefully I can keep it running for a good long time, hopefully into the 100 episode level. Today I get to talk to Dr. Robert Duggan, who is a podiatrist, and he's worked with USA Volleyball. He's worked with professional hockey. He's got a wealth of experience, has worked with a lot of diverse populations, and so he makes some good points on how the feet can affect athletic performance. So I know we all know that already, but a lot of us, I feel like, forget on how important the connection of the foot is to the feedback that we get for the rest of our bodies. Having our feet in shoes 24/7 can really dampen our tactile feedback and also our organization of the other structures around our feet, if that makes sense. This one's got a lot of good things, just like all the others so far. So without further ado, here is Dr. Robert Duggan. Dr. Duggan, thanks for being on today. I really appreciate your time. I'm super excited to talk to you.
My pleasure, Juan. It's a pleasure talking to you today.
So for the listeners at home, would you mind just giving us like a brief kind of overview on your career and how you ended up getting into, podiatry and being an ATC and exercise physiologist, and just kind of touch on where you are now?
Sure, happy to. I started life, so to speak, at Canisius College in Buffalo, New York, and finished pre-med and athletic training program there. Mm-hmm. I got certified with NATA back then.
Okay.
Went on to podiatry school in Cleveland, Ohio. Finished that. Went on to a residency in St. Louis in reconstructive foot and ankle surgery. And then from there, went out to San Diego, worked with San Diego State, San Diego Sports Medicine. Mm-hmm. And we took care of a lot of the teams in that area, including a lot of the San Diego State teams, as well as USA Volleyball, and a whole lot of interesting sports medicine happened for me out there.
Okay.
And then got recruited to join a group here in Central Florida, and I've been in Orlando, Florida for 25 years.
Oh, wow. Okay.
And my next move will be up to North Carolina.
Let's go. Okay. Good stuff. That's awesome. How did you end up getting, so what drew you to be an ATC and also, getting that background in exercise physiology?
Well, originally, I finished my undergrad and got my ATC, and mm-hmm. then had an opportunity to either go with a professional hockey team mm-hmm. or a college soccer team. Mm-hmm. And in my mind, I thought, well, if I got that at this point, I might be able to get that later. And I had a very good friend that I taught skiing with in Western Europe, who was a podiatrist, and
okay.
he encouraged me to at least look into it.
Mm-hmm.
And I did, and I applied to one school in Cleveland. It was close to home, and went there. And actually, from that point on, everything was kind of doors open because of my sports medicine background.
Okay.
And so I ended up teaching some athletic training out at in San Diego.
Yeah.
In my residency in St. Louis, I taught a sports medicine course at Washington University too.
Okay.
And then at my time in Orlando, mm-hmm. I went through a doctoral program in exercise physiology, mm-hmm. and that was a great education. I enjoyed that a lot. And so now I have a lot of different hats, but most of it is just because I wanted to get a background to understand the athletes better.
Okay. And I think you touched on a couple interesting points, right? So you mentioned professional hockey, and then you also mentioned working with USA Volleyball, right? So would you touch on your time with the Buffalo Sabres and USA Volleyball and kind of what your biggest takeaways were from those organizations?
Sure. Early on, back when in my undergrad and then time with just out of undergrad, mm-hmm. I worked with strength and conditioning guys with the Buffalo Sabres, so we did a lot of their strength and conditioning. Mm-hmm. And I worked with some of the strength and conditioning coaches back then for them.
Okay.
And then I actually was the head trainer for the junior Sabres for 3 years. And that was a lot of fun. Jim Lorenz was the coach, and Jim was a great guy, a great coach.
Mm-hmm.
And I had a very interesting time with the Junior Sabres. Matter of fact, I threatened my family to go back as a hockey trainer if I ever, decide to do something different.
Yeah.
Because I did have such a great time, and they're great athletes, hockey players. If you let down in hockey,
mm-hmm.
you get injured, and it's a different sport because of the demands on the athlete. The time you're on the ice, it has to be 100%.
Yeah. Okay.
And that's when injuries and poor performance leads to injuries
mm-hmm.
at that point. And so that was the biggest takeaway I took from my time with hockey, was that you have to be at 100%
mm-hmm.
of your ability for the 40 seconds, 60 seconds on the ice, whatever that time frame is. And with volleyball, I ended up being able to work with U.S. national teams, men's and women's, and beach volleyball, and the appreciation I got there was that athlete
mm-hmm.
has to have a skill level matched with their physical ability. That's, I think, underappreciated. I think the skill level that has to be tuned with the physical ability to perform in our volleyball players, so much so that we were able to appreciate very subtle shoulder weaknesses in our volleyball players out there that translated to multiple points if it wasn't addressed, and that would happen in each arena.
Yeah.
For me, it was, if they stopped in the wrong spot under a net,
mm-hmm.
If you were at the net, that in many times translated to an ankle injury. And so, skill level tuned with the athlete was my biggest takeaway from volleyball.
Okay. And then kind of going back a step, right? So you talked about the uniqueness of ice hockey. And that's one of the sports that's super interesting to me, probably because I just haven't had that much access to it. Will you talk a little bit more on some of the unique aspects of training ice hockey? You're on the ice, so that's already a different aspect. And then you're on skates, right? So you have a lot of demands of the other sports, but also I feel like a lot of things are taken away in terms of what you can do just because you're not used to the ice, right? Does that kind of make sense?
Yeah, as the level of participation increases, the ability to skate becomes less and less a differentiator, and so at higher levels, these athletes are tremendous skaters, and so you have a combination of both, physical, physical injury because of contact. So the amount of contact you have is tremendous in hockey, and then you have a projectile. There's not too many sports, that have a projectile. The volleyball is a projectile. In volleyball, it's very similar in hockey, but it's faster, harder, and in many cases, can be more damaging depending on where it hits. And so not only do you have to be aware of your own skill and your own place on the rink, but you have to be very cognizant of the projectile and the ability to take on a check, and that physical component to hockey was kind of amazing.
Yeah. No, that's really cool to think about. It's just there's so many factors that go into sport, and then you pick a sport like hockey, right? And there's so many more. So that's super interesting to hear. And then kind of moving forward with that, right? So one common thing that all sports have is your connection to the ground in some capacity, right? In swimming, you're connected to the board before you dive into the pool. And in all other sports, it's very apparent that it's a ground-based sport. So what are some common dysfunctions of the foot kind of ankle complex that you've seen that can be avoided or attenuated if early action is taken?
Well, it's really funny. One of the things that I see, and it's across all sports, is shin splint type pain.
Okay.
And we even take a lot of our running athletes now, and I put them through a shin splint class where we try and maximize ankle joint dorsiflexion. We try to increase the swing phase muscle of the anterior tib for strength in that component, and in many cases decreases the relative stress reaction to the mid shaft of the tibia.
Okay.
And so a lot of that shin splint type mechanism is seen across sports.
Yeah.
Even in our swimmers.
Okay. Really? That's interesting.
Our swimmers will cross-train.
Oh, okay.
And in many cases, a lot of the things that they'll do if they're running or they're doing stadium steps, I hope they're not doing a lot of them, but if they're doing those, we start to see that weak anterior component of the lower leg, kick in again.
Yeah.
And they get pain with kicking. So even when they're not actually closed kinetic chain, on the ground, we can still see the effects of the relative imbalance in strength in the lower leg.
Uh-huh.
And of course, the other thing is stress fractures.
Okay.
We'll see across the board some level of stress fracture. Even in our conditioning athletes with stress fractures at the forearm and the wrist. Plantar fasciitis is like a dirty word to a foot and ankle doctor, you know? And in many cases, that is seen because of just a change in activity, a change in body weight, or a combination of both.
Okay.
So we see that across the board in our conditioning athletes. And so a lot of what we'll do is, preseason evaluations, we'll look at things like range of motion, the ability for the ankle and the lower leg to function synchronously to avoid the common stress injuries. About 1 month into our track and cross-country season is when we see the shin type complaint progress on to tibial stress syndrome and plantar fasciitis and stress fracture. So it all comes as a package, unfortunately.
Yeah. Okay.
So we try and get to the athlete early in the preseason times to be able to avoid that.
Gotcha. Okay. So for somebody like a strength and conditioning coach, right? So say they don't have access to someone like you that does these kind of pre-tests, some of these evaluations and analyses. What's something that we can do in a setting like that to look at some of these things?
Sure. Things like symmetrical range of motion. Asymmetry is a really good key, and our strength and conditioning coach are really well tuned into a lot of that. And so as a strength and conditioning coach, I would think that they would be one of the first ones to identify asymmetry in our athletes.
Most definitely.
Whether it's either in morphologic development or range of motion or strength. And that, in many cases, the inability to strength train or to obtain symmetrical range of motion, right to left side or involved versus uninvolved, is one of the first keys. And so that would be one of the things that I would ask our strength and conditioning coaches to let us know early on, is any type of asymmetry. Even like leg length discrepancy. Leg length discrepancy, it has to be either, sometimes you actually have a bone that's longer than the other.
Okay.
And it's structural limb length discrepancy. There's something either because of growth and development or because of genetics that creates a limb length change, or it can be functional.
Okay.
For example, if we have more motion on one side than the other in the hip, we'll get a functional limb length discrepancy.
Okay.
And so to be able to identify, any of the asymmetries as being either structural or functional, let's say you don't have that ankle joint dorsiflexion. You take that ankle joint to an end field where the end of that motion ends, and how does that feel? Is it springy? Does it feel like it's a bony block? Those types of cues can tell us whether or not this is something that can be improved or not. Okay.
So with that leg length discrepancy, right, how common do you see a true like morphological leg length discrepancy, and how common is it that it's more of a functional thing?
Most of the time it's functional.
Okay.
So, especially when we get to athletic performance, we kind of, self-weeded out, for lack of a better expression, some of those athletes that are going to have a lot of structural deficiencies that would keep them from strength training and conditioning and endurance athletics. So a lot of what we see are secondary events because of either injury, immobility, changes in strength and conditioning that create a functional change in limb length. And, in many cases, we can condition them out of that, or we can strength train them into a better position.
Okay.
Sometimes we have to temporarily put accommodations in the shoes or things like that.
Yeah.
Most of the time we don't want to put the athlete into a a permanent position of compromise.
Yeah. No, that makes sense. Kind of going off of that, right? So it's not necessarily permanent, but most athletes are always having their feet bunched up in shoes, right? 24/7. And so if you think about it, right, the magnitude of something like that, taking away a sense of your feet and being able to get that tactile reflex. So how can we combat that, right? Because if an athlete has their shoes on 24/7, and even when they go home, they're in some kind of slipper or some kind of shoe, right? Then they can lose function of that windlass mechanism. So how can we combat that, and how much more likely are they to be injured if they are in shoes all the time?
Yeah, I think that's a great question. One of the things that we do with almost any type of rehabilitation in closed kinetic chain or with foot to ground, basically we're going to ask them to be, unshod. They're going to be doing balance and proprioception exercises. And that allows all of the intrinsic muscles to fire. And that you bring up a good point that the shoe kind of puts them in a position where they have a board on the bottom of their foot, and it has to function as a whole. Yeah. Well, a lot of our intrinsic muscle weakness will happen, as the foot is unshod, and so a lot of our strength and conditioning will be barefoot. Okay. I love the bongo board or the balance board. It's been very effective with total conditioning for lower leg. I love single support balance. Eyes closed, eyes open, eyes closed, and then even a slight raise like a foam pad that gives a little bit of change. Okay. It forces the athlete, especially when you take away some of the other senses. We'll even have them put their iPod, earplugs in, and we'll have them close their eyes, and that takes away a lot of perception, and it allows them to fire the intrinsics into strength training. And you'll see a lot of deficits that way. You'll identify time lost out of balance. Years and years ago, we did a balance evaluator, digital balance evaluator that measured touches right and left as you balanced on a balance evaluator, and we found out that during an injury, the athletes will spend a lot more time over that acutely injured limb because they won't have that ability to compensate. So when they don't have the ability, they'll take center of gravity and they'll move it over towards that injured extremity. And then as they improve, start to more centralize the center of gravity. Okay. So one of the things that we've seen is that in those cases where you have that injury, look for the athlete protecting one side or another. Okay. Gotcha. No, that's good. And then another thing that you touched on, plantar fasciitis, right? So if an athlete is diagnosed with plantar fasciitis or does have some kind of fascia pain, how can we treat that in, say, the strength and conditioning or college setting, or how can we not necessarily treat it, but how can we, lessen the impact for the training session? Yeah. Sure, and one of the things that happens is that plantar fasciitis 99% of the time is treated without anything aggressive. Okay. It doesn't need surgery. Yeah. I think a lot of the plantar fascial releases are done prematurely. In many cases, when plantar fasciitis doesn't get better, it's not plantar fasciitis. It's likely something else. Yeah, that's a good point. Tarsal tunnel syndrome. Okay. Calcaneal stress reaction. There's a lot of things that come into play, but the big thing for our strength and conditioning coaches with plantar fasciitis is the condition shows up with an aggressive change in either activity, body weight, or combination of both. And so, evaluating history and when you start to see plantar fasciitis in your athletes from one year to the next is a pretty good clue. If it shows up a month into conditioning or training or a month into the season, we know that it probably is that area has been a little bit too much too soon at some level of strength and conditioning. But the interesting thing that we see is that if we do that same cadre of exercises and stretches for shin splints, we see plantar fasciitis quiet down. So we see bent knee and straight knee tragus soleus stretches
Mm-hmm.
I do them non-weight bearing in the acute athlete because all you do is aggravate that muscle tendon unit.
Mm.
So we do non-weight bearing knee straight, knee bend stretches. Frozen water bottle is excellent for the plantar fascia.
Okay.
Again, it can be done to the point of comfort, especially in the acute athlete.
Uh-huh.
And then in many cases, this is kind of the team approach. We have to find the timeline for this plantar fasciitis. Is it acutely inflamed? Are we looking at an acute inflammatory process that may respond to anti-inflammatories? Or are we looking at now a chronic irritation, or are we looking at a compression of a nerve? So
Gotcha.
a really good diagnosis, kind of the team approach to this is really kind of the answer.
Yeah.
And then we got to get the coach into the loop with, this athlete may require a little bit of decrease in intensity for the time that it takes us to get them better.
Gotcha. No, that's a good point. And I mean, anytime you talk about athletics, right, coaches are going to want to maximize the time that their athletes are playing, right, because that's where they brought them. So with that, you get a lot of coaches that require ankle braces and things like that. What kind of effects does that have on the athlete as a whole, and especially that ankle complex?
Well, what I've seen over the years, we started using ankle bracing with our volleyball players it started in '88, believe it or not.
Okay.
And we've had some really good success.
Yeah.
Depending on the brace, if you're immobilizing the ankle enough to make it immobile, where you decrease normal motion, you run the risk of increasing more proximal kinetic chain injuries. So
Definitely.
The selection of brace needs to be very careful. I don't get paid by any company, and I don't have a horse in the race here. Yeah. But we've been using the ASO, the ankle stabilizing orthoses, for years and years and years. I have yet to see it create an injury, and yet it does block that extreme motion in both ways.
Yeah.
Gives some compression. And what moms and dads like for our younger kids is it doesn't ruin the shoes. Our equipment managers love us because we're not, toasting a brand new pair of cleats with an ankle brace.
Okay.
So I like that. It can be, it can be functional from early injury right straight through to continued play and return to competition. I have yet to see it create any more proximal injury, and we can strength train and rehab right through it.
Gotcha. Okay. I'll have to look into those braces. No, that's a good recommendation too, because a lot of these kids, like, they're required to get braces, but no specific brand, right? So they'll just go out and get whatever is accessible, which oftentimes is not the best. So, no, that's a good point.
And that brace can be sized fairly easily as well.
Okay. Good stuff. You sure you don't have a horse in this race?
No, I wish I did.
Fair enough.
That brings up an interesting point. I've purposely over the years not aligned myself with any companies. I think it clouds your objective opinion on how you can best treat the athlete. So
no, I agree.
I've had many offers, but I've turned them all down. I don't think it's a reasonable thing to do as an active practicing physician. Yeah,
and I mean, it can affect the integrity of your job, like you're saying, right? Because then it's like, why do you do it? Do you do it to get a little bit of dollars, or do you do it for, what you originally got there for? So
it makes it a lot easier to say no thank you.
Yeah, definitely. Moving forward with feet, ankles, right? So big part of athletics and just human life in general is gait, right? And so we can learn a lot about a person by watching their gait. So let's talk about some gait analysis and some things that you can learn just from watching an athlete move, like, say, just walk into the room, right?
Sure. Yeah, that's when it all starts, really. And you look at, how do they walk without them realizing that they're being watched? And that really is kind of a lot. Early on in my practice here in Orlando, I had a 5-camera gait analysis system with videotaping.
Yeah.
I had an in-ground force plate gait analysis, and we gave it all to the university, basically, because it really was a lot of bells and whistles, really neat for research, but it didn't really give me any additional information that I couldn't tell with exam and the patient's history. Yeah. So we tried to save a lot of money by not having to charge any of the patients for that. And what we found out is that the gait analysis is really key when you see, again, those areas of weakness. When you see asymmetry in a gait, the athletes are going to show that fairly quickly. Again, the acute injuries, they're going to favor the side of injury. Later on, or very acutely, if they can't weight bear, they'll be off that area. As they progress, they'll go on to that side of the injured side because it hurts to move it beyond its available range. Mm-hmm. And then as they get better again, they start to more normalize their gait.
Okay.
And one of the things that we see is, the gait analysis in many cases will help us identify the apex of the problem.
Okay.
So if we see a loss of ankle joint motion or knee extension, mm-hmm. we start to say, okay, well, we're seeing the loss of knee extension. Why is that? It may be because there's some intrinsic changes to the knee, mm-hmm. and it kind of gives us that. It almost points an arrow to the area of injury. Okay. And so when we find the apex of the deformity, mm-hmm. then we have to find out if in fact that's the reason for the gait change, mm-hmm. or is it a secondary presentation because the athlete's been compensating?
Okay.
And that's a more difficult assessment.
Yeah.
That takes a little bit more time. Uh-huh. With the gait analysis, I'll always say, tell me when you're in pain. When and at what part of the gait cycle mm-hmm. is pain reproduced? Is it in the swing phase? Is it a stance phase? And that kind of eliminates half the gait.
Okay.
Are you painful on the swing side when the opposite side is weight bearing? Mm-hmm. Are we looking at hip issues that are because we're, weak in a particular hip condition?
Yeah.
So we sort of are a slave to our genetics.
Yeah.
But if we can find the apex of the deformity, mm-hmm. and then I always tell the residents, you need to find out the tissue planes involved. Mm-hmm. Is it truly the knee joint because we can't extend the knee, or is it because the hamstrings are involved that we can't extend the knee? So the knee may not be extending.
Okay.
But what are the tissue planes involved?
Yeah.
And that goes all the way down to blood flow and nerve function. One of the things I'd love to have our entire sports medicine team get used to doing is to understanding whether or not the patients have full sensorium and really good blood flow, mm-hmm. And get used to that, because in some cases we forget those two systems of the body, the nervous level and the blood flow level.
Yeah. Okay. And then you touched on some nerve function stuff. So do you guys do a lot of treatment with nerve function, or do you refer out, or how does that look?
Yeah, we do. In many cases, compression changes to the nerves mm-hmm. are treated surgically for decompression.
Oh, okay.
Tarsal tunnel is one.
Uh-huh.
We see some nerve compression changes in patients with exercise-induced compartment syndrome. Mm-hmm. And we see some local compression changes with neuroma-type pain and things like that in the forefoot.
Okay.
Also, in some of our distance athletes, especially our triathletes, we see some compression changes at the head of the fibula around the common perineal nerve.
Okay.
And so certainly we want to evaluate that and make sure that we're seeing full function.
Yeah.
And then depending on the individual practitioner, they may or may not treat those conditions themselves or refer them to the appropriate treating surgeon.
Okay. Are there a lot of non-surgical routes, or is it mostly resort to surgery?
Yeah, again, it depends on what we're talking about, whether or not it's an inflammatory condition of the nerve.
Yeah.
Like early on, Morton's neuroma in the foot mm-hmm. starts out just as an inflammatory condition of the nerve.
Okay.
And in many cases, that can resolve with some anti-inflammatory treatment and some accommodations with shoes. Uh-huh. Later on, it goes on to scarring and an actual creation of scarring around the nerve, and in many cases, that's a surgical treatment.
Gotcha, man. That's some super interesting stuff. So, I love it. And just to close this thing out, right? So, what are you working on now, and how can people follow you or reach out to you?
Well, probably, starting in August, I'll be up at Caldwell, UNC Caldwell in Lenoir, mm-hmm. North Carolina. Mm-hmm. And we've right now we're looking at ways of trying to give back to the kids with developing a walking running program for the kids, and developing some smart ways that moms and dads and teachers can get our kids walking and running. Mm-hmm. And the other thing we're doing is developing a sports performance and exercise education component
Okay.
to develop a little bit more knowledge before they go on to college about, what to expect. Sleep, hydration, all those good things, and get a little bit of knowledge before they go.
Awesome. Well, hey, I really appreciate your time, Dr. Duggan. This was greatly valuable. I think a lot of people are going to like this, and so I'm looking forward to talking to you more in the future when you come up here. So once again, thank you for your time.
Great, Juan. It was a pleasure talking with you, and if I can ever be a help, let me know.
All right. Thank you. I appreciate it. Talk to you soon.
Sure thing. Talk to you soon.
A big thanks goes out to Dr. Robert Duggan for taking the time to chop it up and talk shop with me. And a big thanks goes out to you, the listener, for taking the time to listen and follow this podcast. I really do appreciate it. If I could ask you just one more favor, please give it a rating on iTunes because it really does make a difference. Thanks for your time, and I'll see you next week on the Gamut of Performance podcast.